बस वो अभी किया उसने ना, दोबारा जब खत्म हो गया उसने सही जवाब नहीं दिया शम्स ने जो कुछ।
Assalamu alaikum. I welcome you all as moderator of this session. I am Dr. Muhammad Israrul Haq, working as Assistant Professor Gastroenterology in Sheikh Zayed Medical College and Hospital Rahimyar Khan. I am also regional representative of Pakistan Society of Hepatology. I would like to invite Dr. Mozam to come to the stage to chair this session. Dr. Mozam is consultant gastroenterologist in Quetta, and he is also ex-president of Pakistan Society of Hepatology. I'd also request Dr. Hameed to come to the stage to co-chair the session. Dr. Hameed is a consultant gastroenterologist in Abbottabad. For the first state-of-the-art lecture on holistic picture of NASH evaluation and management, I request Dr. Bilal Hameed to come to the stage. Dr. Bilal Hameed is a professor of medicine at UCSF, and he has a special interest in management of non-alcoholic fatty liver disease, and he has many publications on this topic.
Assalamu alaikum, everyone. I have given 2 talks so far. One was the global prevalence of NASH and regional and global prevalence. The second was diagnosis and evaluation. So this will gonna bring, I think, some of the slides, I'll gonna show it to bring it together and try to, mainly the goal is that how do we approach what the future look like in a holistic way for non-alcoholic fatty liver disease. These are my disclosures. So when we look at the NAFLD, it's a silent pandemic with a global health challenge. The scale of the problem is huge, and by the time this slide, like couple of years were made, it was about thought to be 25%, but at 30% of the adult population have it. The problem continues to be a lack of awareness, not only by the public, by the patients also, and a lot of primary care physicians still does not be aware of this problem. It is symptomless, so patient does not have any symptoms. So it's very hard to talk to the patient that why this is important, what's the risk of progression. It has serious consequences, and we'll talk about not only from the liver perspective, but also risk of cardiovascular disease, liver cancer, and other cancers. So it is very imperative that all of us to take an action. We already seen some data shown that fatty liver disease is already increasing as a cause of liver transplantation in Pakistan, and it will become the #1 cause, I would like, hopefully, once we have the viral elimination in Pakistan. From the patient perspective, there's a lot of issue because we think about what from a provider perspective, but it's still a lot of confusion. And we talked about the nomenclature of non-alcoholic fatty liver disease. And again, if you talk to in Pakistan that you have non-alcoholic fatty liver disease, still a stigma that has been associated. And that is one of the reasons in the future that terminology will change, although I explained in my last talk, because of a lot of challenges and a lot of legal, because of the clinical trials and all the things that we have been using, the name of NAFLD still will be there. Again, the awareness continues to come in the play. And then we have this, does not have any holistic approach. We work in silos. We talk about, we blame on each other because endocrinologists are more interested in understanding why their patient with diabetes are developing fatty liver disease. And as a hepatologist, we are like, once you have fatty liver disease, who will develop cirrhosis or advanced fibrosis? So we have to work together and shift the paradigm that even as a hepatologist, and I'll talk about, that someone has to take the ownership of these patients, whether it will be primary care physician, it will be hepatologist, and we'll be treating a lot of these things together. And then again, not only in Pakistan, in America, we have poor access to healthcare. We have seen that fatty liver disease are also in lower socioeconomic condition. It's very hard when you talk about healthy food. It is expensive in anywhere in the world. It is not very cheap to go buy these healthy alternative because a lot of these patients in America, they also live in these food stamp, and you go in and you can buy a lot of things which are cheaper. And so also we are now understanding more and more about the poor quality of life in these patients. Sarcopenia, frailty is more associated, sleep apnea, depression, and also other mental health. So we have to understand that increased burden and also understand patient perspective a little bit better. Now, this is the slide I've shown earlier about the global and regional prevalence. This has been increasing, and the biggest increase we have seen in South Asia and Middle Eastern countries. And some of the estimate, and again, it can change every year, couple of years, but 1 billion people in the world has evidence of non-alcoholic fatty liver disease, NASH, which is inflammation, and at risk about 250 million. And of these, if we consider 9% or will have advanced, which will be already 22 million people. The scope is really big. Now, we also know some of the risk factors which are clearly associated, which are obesity and type 2 diabetes. And the type 2 diabetes will gonna keep coming. So this is the same prevalence, but in patients who have diabetes. So if there's a group of patients that we need to target more, are patients who have diabetes and patients with obesity. But the global prevalence of NAFLD in diabetes is about 55 to 70%, and much higher risk of NASH, and much higher risk of advanced fibrosis, at least F2 or more, which is about 12 to 20%. Again, if you look at Pakistan and India, the diabetes rate is increasing. I showed the earlier data that there's some estimate that 1 out of every 4 person in Pakistan has diabetes. So we will gonna see more cases of fatty liver disease. So the other comorbid conditions that have been associated, but again, the pattern is the same as compared to general population. The risk of obesity, hypertension, diabetes, and dyslipidemia, which be much higher in patients with NASH or patients with fibrosis. Now also we understand that there's increased risk of complications. So if you add both fatty liver disease and diabetes, the risk of cardiovascular disease is much higher, the risk of fibrosis or liver disease, and especially HCC. Dr. Ko has an excellent presentation in the first session of this meeting where he talked about fatty liver disease and HCC, and that is becoming the most common cause of HCC is fatty liver disease. And also we have had some other studies that fatty liver disease are increasing the global incidence of NASH as a cause of cirrhosis, and this is the data from 195 countries. So clearly you can see that incidence of HCC has been increasing from 1990 to 2017. Now this was also a study which they looked at the different modeling and look at what the prevalence in the US and in the future that will gonna look like. And then again, the burden of US from 2015 to 2030, that there will be about 178% increased risk of death. The incident HCC will increase by 137%, and liver transplant is estimated to by 59%. So, we all talked about when the DEA came in that, hepatitis C was going to go down, we'll see less cases, but this fatty liver disease was already increasing, and already in a lot of our centers is becoming the main cause of liver transplantation. So it's a multi-systemic disease, and we need multidisciplinary approach. So fatty liver in the middle, but we know that majority of these patients will have type 2 diabetes, they will have insulin resistance, cardiovascular disease, chronic kidney disease, and I'll show some data will be there, obesity and metabolic syndrome. So when you go back and look at it, again, the diet-induced obesity has been the center of these problems. And it causes this metabolic stress, systemic inflammation, and fibrosis. And same thing happen in multiple different organs at the same time. In liver, when you have advanced fibrosis, cirrhosis, then your risk of cardiovascular disease, liver cancer, and other cancers which have shown the data, not only liver, but we have extrahepatic malignancy. Same thing happening with inflammation and fibrosis in the arteries. You have more hypertension, cardiovascular disease, peripheral vascular disease. Increased data about heart failure in patients with NAFLD. Also with pancreas and development of type 2 diabetes and chronic kidney disease. There's also a whole linear progression of hepatic and extrahepatic outcomes. I'll go back and show the study at least the third time in all of this is the most quoted study these days in our prospective 1700 patients of biopsy proven NASH from NASH CRN. And then again, it shows that when you have advanced fibrosis, your all-cause mortality has been increasing, in addition to all these complications of variceal bleeding, ascites, hepatic encephalopathy. But at the same time, when you look at based on advanced fibrosis or cirrhosis, not only hepatic decompensation, your risk of coronary artery disease, risk of renal function, and extrahepatic cancer also increase when your fibrosis level increase. So this advanced fibrosis is one of the biggest factors that we are worried about in our patients. In addition, what we have also based on this study, that incidence of in prospective this cohort, that we have seen that these patients have more incidence of developing high blood pressure, low GFR, and type 2 diabetes. These were the patients who did not have it early on. So again, same thing, that there's a collinear progression of these factors, not only from the liver fibrosis progression. I also showed this data. The first thing in a holistic approach, that we need to have good pathways. And Pakistan has to come on their own pathway. What is best? And there are some guidelines out there, what factors we will be using, which patient will be seen by primary care physician and which patient need to be seen by a specialist. We don't have enough gastroenterologists and hepatologists even in America that we can see all these patients. So we have these pathways. We have a lot of electronic medical record e-consult system that we advise our primary care physician. And this is just one of those, but the bottom line is FIF4 continues to be, in many studies have shown, as a very important marker. It's very easy to calculate. So if you have it, so at least have FIF4 is the big. NAFLD fibrosis score is also good, but we like. And the FIF4 is not only good for the fibrosis, but also have shown in the studies, also tells about the progression, same way. So if you have this FIF4 score and you divide into the low risk category, if you have low risk, then you just have to repeat it every 2 to 3 years time, and the primary care just can follow these patients. But if you have high risk, you intermediate high risk, these are the patients that you can have to also do different kind of either new biomarker or fibroscan or transient elastography. Now I do wanted to mention ELF, which is approved by Siemens, has been gaining a lot of popularities, and these algorithms will gonna change. And likely I feel that you don't have access to transient elastography in many practices which are smaller practices, but the biomarkers can still be present. FIF4 addition of it, and there's also data that if you include 2 biomarkers or 2 non-invasive, that your chance of finding these fibrosis or advanced fibrosis is much higher. So the first thing is developing in a holistic approach a good pathway that which patient need to be seen. So now the next part of my talk is how we think about the management in a holistic approach. So we do need an integrated, coordinated care model to enhance the patient journey and improve the outcomes. So if you have a patient, we need to have an integrated assessment and care plan. And a lot of us are thinking about how these clinics will gonna look like. And we have some part of it, although there are a lot of financial constraint even in America. But we want to have one-stop shop kind of a thing that we can assess a lot of things together in an initial visit or when the patient comes for follow-up. So the nutritionist is very, very important. We all know how much time we have in our clinic that we can spend and how much knowledge we have about these patients. The mental health is showing again and again, it's very important. There are some addictions that have been associated, and at the same time, when they see the hepatologist, what are the other competing risk analysis? So we need to think about their heart, their brain, the kidneys, and pancreas together. Importantly, even in America, we have so much diversity that if we can have one size does not fit. So we need to come up with plan that what is their tailored and culturally appropriate way to talk to these patients. And same in Pakistan. We can't just like have a guideline from EASL or ASLT you can implement in America and that we in Pakistan, and we cannot make those mistakes. What are the food? How do we work with our own nutritionists and advise these patients? So how we think about, again, even in America, the primary care should still be the center of it. And in America, we call there the quarterbacks, right? They will decide who to pass the ball to. But then in some places, I know that some of you are in the practice. I know Dr. Professor Alam, he has been taking care of these patients on their own and prescribing a lot of these medications. But then we have in our future clinic that we are working on, and I'm working at UCSF, that our patient will gonna come in and they can see a nutritional specialist. We have an endocrinologist there, and depending on what other factors that they can see a cardiologist if we wanted to have, and especially we have access to our weight loss clinic and bariatric surgery clinic. Now, going back and showing the same slide, that we have different background of therapies which are already available, and how we use those therapies right now to improve the cardiometabolic and liver disease. So if you have a patient, we look at the heart, and the weight loss becomes important in every risk factors, right, in every organ. So that is the most important factor that we keep talking to our patient. But at the same time, we know how many of these patients will actually achieve the weight loss, but we still keep counseling on that. The angiotensin receptor blockers, the GLP-1, statins and fibrates, and smoking cessation. There is also data coming out that smoking also not only increased the risk of HCC, but also their association with fatty liver disease. So you have to counsel your patient on smoking cessation. The heart is the heart failure. So these SGLT inhibitors are also very important. And liver, we're going to talk about the GLP-1, which has gained a lot of popularity, although the clinical trials are coming up. Now in pancreas also, we have a lot of different options available. And then same for the kidneys. We have to think about their kidneys and look at what are the... So if you see in this slide, the GLP-1 inhibitors, based on the mechanism of action, are working in a lot of different pathways. And this is one of the important, I think, addition to our armamentarium, and hopefully this will be in some way we'll be using. But a lot of us are using off-label semaglutide even in our clinic, who has either for weight loss or for fatty liver disease. Now what in your practice that this is how we think about it. If I see a patient, although primary care if not been doing it, is that we need to make sure to on every visit, or at least initial visit, you need to know what their blood pressure is. You need to check your lipid profile and look at there is some data about CRP, but you can argue. Always make sure that our patient has an EKG, or if additional testing is needed, we'll go from there. And again, FIF4, you can just start with that, or especially through the primary care. We need to make sure that diabetes testing with hemoglobin A1C and plasma glucose and checking their kidney function. Now, critical role of behavioral factors in metabolic syndrome and NAFLD. There are a lot of studies in diabetes and metabolic syndrome, and same thing will be coming in. We are understanding more genetics, economic impact, the social impact, cultural, and also political impact. We need to have political force to address this as a whole, as a nation. And then we work on their behaviors, and also then understand which patients are at risk of progression, which can be just followed by primary care, and so we can identify those patients in a better way. Now, when you talk about the goals of therapy, besides overall looking at it, whatever we want to think about their fatty liver patient, we need to manage or work on glycemic and cardiovascular risk. So hepatic fibrosis, if someone has, we're working on regression of fibrosis. If they have inflammation, we also have shown that if you have improvement in inflammation, you will improve the fibrosis, because that's the driver for fibrosis. Obesity, type 2 diabetes, and dyslipidemia. But whatever treatment we want you to do, and what's the future state of any clinical, trial or any medication that will be improved, it has to be healthy to the heart, because these patients will likely be on these medications for a long period of time. So we are very excited for the addition of several of these medications, including semaglutide, but this tirzepatide, which is Mounjaro in America, is amazing. If you look at the studies about how many of these patients have lose almost like 20% of their weight loss, this will gonna change, hopefully, the field, and this is one of the important thing, and so we are, excited about these. There's a lot of many clinical trials using GLP inhibitors, and also there are other compounds that will be important to see in the future. So lastly, the drug therapies. We know that there are no FDA-approved medications right now, but the problem with the clinical trial also is that FDA still require that you need to have a histological improvement. You need to have a liver biopsy to approve any medication, and there are different guidelines whether you have NASH resolution or fibrosis. Although they do understand these trials will be longer, so if you have a histological endpoint after 2 or 3 years, you can have a conditional approval, but you need to have a clinical endpoint. You need to show that these medications in advanced fibrosis will lead further to have clinical outcomes and everything. So that's why these clinical trials, we are running some of these trials for 4 or 5 years and now waiting for the data. The problem with clinical trials is that there's a lot of heterogeneity in the population and lack of diversity. It's mostly done in white population or Caucasian. We don't have that many Asians and other minorities. So even if these medications shows whether it will be applied to our disease is such a slow progressor that we have to do a longer trials. It does require liver biopsy, and we all know the liver biopsies are not, there are a lot of heterogeneity how pathologists. There are clinical trials who actually they spend millions of dollars, and because of the pathology and then how the pathologist read it, the trial was not successful. And there is a lot of variability, and there is a new trend about artificial intelligence and other things. And what one of my mentor and great NAFLT Arun Sanyal always says that the pathologist has kept us a little bit behind because of that field, although they describe the field. So there is a big amount. And then a lot of these studies about amount of alcohol, and that also have an impact. And so we need to better define that. So these are just giving you idea about how many agents in development. I still remember when I was a fellow and as an early attending, when I used to go to the hepatitis C talks, and I'm like, oh my God, I can't understand these, like there's so many. So, but I'm just trying to tell you, there's a lot of money, because if you look at the economic impact of billions of dollars, so there are every pharmaceutical industries everyone wants to get into, but they are realizing that it's not an easy field to, because even the outcomes that we are looking is not as simple as hepatitis C and looking at the SPR. So this is some of the summary of some of these multiple agents. So there are two in the oral agents and injectable, right? So FXR and PPR agonists and THR, so there are a lot of different pathways are there. But again, if you look at the GLP-1 inhibitors are very important. And the one thing I just wanted to mention, this compound of GLP-1 and glucagon agonist, cotadutide, is very promising, and it just entered the phase 3, or they're starting. So the combination medication working on different agents will likely be the future that we are looking at it. So this is like, it's still a valley of death for a lot of these medications, and there are a lot of medications have been failed. And so, but this is what we were gonna see, just like in other diseases. But there are a lot of, I have been unfortunately part of like 4 or 5 of these studies, and then you have to tell the patient it's not working. But again, this is not very easy to enroll, because these patients look perfectly fine, and when you do tell them you have advanced fibrosis, sometimes they don't even believe you. And these are the agents in phase 3 clinical trial right now. The semaglutide data looks promising. Again, we have to wait. The phase 3 clinical trials are ongoing, and there are also trials going on in cirrhosis population, so we have to understand. One nice trial that the Maestro clinical trial, that's the first trial in phase 3 that they have an arm that they're not requiring a liver biopsy. And I think that will gonna be improving the field going forward, that there will be trials with better non-invasive that we would not need to, because that's a bigger limitation in the future. So in the end, what is the management of paradigm that we are seeing for the next 5 years? So the important thing is we still have to assess the end organ status, like for the initial diagnosis, and we start some kind of a weight loss regimen, whether it needs a medication or not. Importantly, statins are completely safe, and in fact shown that have decreased cardiovascular benefit also. So don't get worried about starting statins or fibrate, the GLP or SGLT pathway, and we actually minimize the use of insulin in these patients. Now, you have more advanced disease, like you have active disease or F2 or higher fibrosis, then we are more targeted towards the NASH therapy. And that's where we are looking into liver specific, whether it's clinical trial or GLP inhibitors more aggressively included. And then we have to improve the health. And we have to work on not only improve their mortality, healthcare costs, their functional status and quality of life. And that would be very, very important in a holistic approach. The need for national programs, I think, will be very important, because we cannot do it alone in that. And that's where the hepatitis C elimination, and we have to combine. And that China has this Healthy China 2030 program where they're treating obesity and type 2. Egypt, when they're checking their hep C, they're checking their weight circumstances. And so I think that, and Korea has this metabolic syndrome management. So I think it is time that one of the idea that, when we talk about the hepatitis C elimination, people are worried and don't want to get. So maybe we have an healthy Pakistan or healthy liver kind of a program where you can not only do viral hepatitis screening, you can provide them vaccination, check for their FIF4, diabetes, and then I think that may be one thing that as the PSH or other societies can come together, and I think that would be the need, because our country cannot afford the cost of the healthcare that will gonna come for these disease, especially fatty liver disease. So what will be control, and this is my last slide, to NAFLD disease pandemic? We need to have a pronged approach. We need to have a systemic investment to enhance awareness and improve healthcare choices. We have to involve the media. All these commercials that we are talking about with the sodas and all those things, we need to actually think about it. Improve surveillance and tracking of the burden of the disease. We need to have a better pathways that which patient need to be seen that will be cost effective and enhance the outcomes. Integration of approaches rather than siloed one organ will not gonna work. We have to work together and take the ownership of these patients and ultimately working together in all these organizations and come up, but you have to come up with our own model in Pakistan because we have seen that the models other places, every country is different, every issue is different. So thank you so much and for
Thank you, Dr. Bilal, for such an elaborative discussion.